Hi, everyone. Good morning. Thank you for joining me today. My name is Marlliny Sullivan. I am from University of Estácio de Sá in Rio de Janeiro, Brazil. And today we're going to talk about approach to vertigo and dizziness, and also about the Mal de Débarq syndrome. So this is just an outline. We're going to start with a quick introduction, and then a classification of vestibular symptoms, how to evaluate patients with dizziness, history, examination, lab testing, vestibular testing, and imaging study, which will be very quick, just for interest of time, and then Mal de Débarq syndrome. To start, I'm going to share with you a case of a patient we had last week in the office. So a 50-year-old male patient with a past medical history of hypertension and GERD presented to the office referred by an ENT physician. He complains of dizziness and imbalance for 8 months. So this is all the information we had at the time when he first arrived. So what is the best next step for evaluation of this patient? So letter A, ask to the patient to describe more accurately his dizziness. B, obtain time and associated symptoms. C, check previous exam results or perform the Dix-Hauppauge maneuver. So what do you think? Any guess?
A,
I would say.
A?
yeah.
Okay, let's see. So actually, the right answer is letter B, obtain time and associated symptoms. And I'm going to explain why. So first, let me share with you a quick introduction. So dizziness is a frequent encounter in the clinical settings, right? So we see it in ER, in the primary care settings, and now in neurology too. The lifetime prevalence of having significant dizziness is between 17 to 30%. So it's pretty common. And a recent study showed that 60% of all the patients, they are female, and they are around 15 to 60 years old. And actually, the same study showed that only 14% were patients more than 70 years old. And in the past, we believe that dizziness were much more common in the patients that have more than 70 years old. So this recent study showed a difference. Peripheral vestibular disorders are common, but half of the patients with dizziness have a non-vestibular mechanism. And once, no problem. Is it okay if I continue? Oh, no.
Yes.
Yes, okay, no problem. So 1/6 of the patients presents with 2 causes of dizziness at the same time. So this study also showed that it's a big portion of the patients actually have 2 causes of dizziness. And the most common combinations were vestibular migraine and BPPV, and then vestibular migraine and Meniere disease. Many patients with dizziness see multiple healthcare providers and feel frustrated, misdiagnosed, and misdirected. So that's why it's so important for us to keep studying and trying to get enough experience so we can ourselves see and make some patterns to help better our patients. So there is 2 principal classifications of vestibular symptoms, and they are like actually totally separate entities. One is vertigo, which is the sensation of self-motion. When no self-motion is occurring, or the sensation of distorted self-motion, during an otherwise normal head movement. And dizziness, which is a sensation of disturbed and altered spatial orientation without the feeling of false motion. So this is actually show us that unlike common teaching in the past, the International Classification of Vestibular Disorder System does not consider vertigo to be a subtype of dizziness, but rather a separate description from dizziness. Okay. So a patient can have vertigo and dizziness at the same time. So how can we actually evaluate this patient? How can we do it? And so I'm gonna start with a very fast overview. There is 4 different ways to evaluate patient with dizziness. The first one is assessing the pattern recognition. It's basically focusing in the history and examination to identify patterns that best fit with a specific cause or causes. It's usually advantage for neurologists, especially because neurologists do it every day, right? But the only problem is that it take time to take the history and do the full examination. At the same time, take time to get experience. So we as physicians to develop this like a mental pattern recognition. Another way is just using the International Classification of Vestibular Disorder that divide the vestibular disorders in three different groups. One is acute vestibular syndrome, another one episodic vestibular syndrome, and then chronic vestibular syndrome. Another way is using the acronym from timing, trigger, associated symptoms, and target examination. This is more used in primary care and emergency settings because they need to keep their history short. And the last one that actually you choose during the last question was the symptom description. The problem is that this way to evaluate the patient dizziness was actually established in 1970s. So it's an older way to examine, and it's based on categorizing the patient's descriptions of dizziness as fitting into 1 or 4 categories, like vertigo, is it presyncope, is it impaired equilibrium, or non-specific dizziness. But data from over the past dozen years made apparent that this actually can lead to more misdiagnosis, because sometimes it's hard for the patient to actually express how they describe and how they feel the dizziness. So these latest studies show that it's better actually to compare timing, triggers information, or associated symptoms to come with some differential diagnosis. So how can we do a very good history of the patient? Is also using from empathy and gathering important information. I know you are all very familiar with taking a good story, but I just wanna call attention for a very important aspect, which is like also like trying to start the history with an open-ended question. And of course, sometimes we have to redirect the patient in some cases. But of course, we have to assess for symptom descriptions, onset, duration, triggers, associated features, previous treatment, and which is what is very, very important, and ask the patient what's the impact on quality of life and what they expect, what are their goal with the treatment. Like I said, sometimes the patient's description of dizziness and vertigo can lead to mistakes in diagnosis, but some patients accurately describe spinning, whirling, and rotational sensation that do indeed imply a higher likelihood of vestibular process. For example, if a patient has this clear vertigo, like he can say, oh, I feel spinning, I feel that there's a rotation, you can then assess the timing. If the spells less than 1 minute, then PPV, vertigo, should be considered. If the spell lasts minutes, we have to assess for TIA or vestibular migraine. And if the spell lasts hours, many disease of vestibular migraine may be the cause. Physical exam is also a very essential part. The first thing, we have to observe the patient gait. Can he walk by himself? Does he need any help? Has any specific gait? So that's the first step. And then we can do an evaluation for potential related signs like Horner syndromes, hemisensory deficit, also trying to find signs that localize vertigo and dizziness to a central nervous system location. Otoscopy is also very important, that sometimes we don't use it, but it's very helpful in excluding obvious like cerumen impactation or cyst or perforation. And it's also important to perform orthostatic vital signs if you are suspicious that the patient have orthostatic hypotension or intolerance. Like we have to check the BP when the patient is on supine, sitting, and standing. Another way to perform physical exam is observing the patient's eye movements and if he has nystagmus. This is actually very important. The classical way to differentiate central from peripheral vertigo is doing the head rest test, this one, and do the test of skill, and also looking for the nystagmus. So I brought here this is a video of downbeat nystagmus, which is very, very classic and should be considered a central finding. That localized should be to the cerebral vermis or cervical medullary junction. So I'm just gonna show. Let me know if you can hear.
The hallmark of downbeat nystagmus are downbeating jerk nystagmus in primary position of gaze. Typically, as in this patient, they're accentuated in down and especially down and lateral gaze. Note how the oscillations are more prominent when the patient gazes lateral and down. These are also a localizing nystagmus. When seen, it should suggest a structural lesion at the cranial-cervical junction. Most commonly, this is an Arnold-Chiari malformation.
Okay, so this is a very classic finding. So laboratory testing is really, really important too. So if the patient is using antiepileptic, make sure you test the drug levels. If he has impaired balance, vitamin B12, methylmalonic acid, hemoglobin A1C, and thyroid functions can be assessed. If he has orthostatic dizziness, CBC and SYMP. If he has bilateral fluctuating hearing, or you suspect that he has autoimmune inner ear disease, make sure you order the antinuclear antibody screen, ESR, and test for syphilis. If the patient has ataxia, you should also check for GAD65 antibodies and possible vitamin E level. Remember that the anti-GAD65 antibodies are associated with stiff person syndrome, but in some cases, they can manifest primarily with cerebral ataxia, with imbalance and dizziness, and oftentimes, like we saw on the last slide, downbeating nystagmus. And we have the other laboratory testings of course, we have to make sure to exclude any cardiac reason for the dizziness. We can assess for EKG, echocardiogram, Holter, or even refer to a cardiologist. We can assess we can do the nystagmus testings with ENG, VNG, evoked potential, and brain MRI and CT. So let's go back to our case. So this patient, like I said, he was with dizziness and imbalance for 8 months. And he described his symptoms as rocking in a boat at sea and occasional bilateral tinnitus. His symptoms had spontaneous onset after watching TV, tend to last 4 hours, and got gradually worse. He feels better with movement and exercise, and worse with bright light, staying still, and when he is in a closest place. Current medication is meclizine 25 milligrams and lisinopril 40 milligrams. The patient also worked in Navy for 20 years, but retired 9 years ago. So he had like a history of like traveling a boat. Canyoneers were normal, all the physical exams were normal, all the vestibular tests were normal too, and the brain CT was also normal. So after further considerations, the patient was diagnosed with Mal de Débarq syndrome. So what is the best treatment options for this patient? Should we continue meclizine 25 milligrams and gradually increase the dose? Should you give him corticosteroids, clonazepam and SSRI, or vestibular rehabilitation therapy and avoid to stay still? What do you think? Don't need to be shy.
Very good.
See? Okay, so wow, I'm impressed. You guys did it very well. Everybody said C. Very good. So actually, this patient was Dr. Bernard started with clonazepam, and he's doing much, much better. So let's talk a little bit about the Mal de Débarq syndrome, the sickness of disembarkation. So our current understanding is that the patient have oscillating vertigo. So he described it like as rocking, bombing, swing, and this often it occurs after prolonged exposure to motion. So this patient actually said that actually he feels like he's still on the boat. Any kind of persistent passive motion can precipitate the symptoms. For example, if the patient lives in a waterbed, if he lives in on houseboats, even if he runs or on a treadmills, or even if you take an elevator, can precipitate that. But while in most time it presents after a travel, some onset appears to be spontaneous, like our patient, and without a motion event. So this is just a graphic showing that the boat is the majority, corresponds to majority of the cases. It typically happens in women between 40 to 50 years, and majority of them are in perimenopausal. So the patient is very rare because he's a man and is a male, and because he's here too in the between 50 to 59 years old. The hallmark of the disease is the reduction in motion perception with re-exposure to motion, such as driving a car or getting back on the boat. So the patient, he feels better when he was like doing exercise, when he was moving. And the symptoms can exacerbate in closed space and space with poor focal points like a grocery store. And unfortunately, if the symptoms last more than 6 months, it's generally very difficult to have spontaneous remission. So even that the patient is having clonopin, is taking clonopin, he said he's feeling much, much better. Before he couldn't work, now he's back to work, but he still have a little bit of the dizziness sensation. It's not, he doesn't feel 100% cured. And there is some associated symptoms like fatigue, dizziness, headache, tinnitus, and anxiety. And usually the physical exam is totally normal. You don't see nystagmus, any extraocular abnormalities, no hearing loss or spinning vertigo. So to help us to understand better what actually the patient feel, I want to share this quick video that shows exactly how the patient see his life when he's experienced his symptoms.
This is life with MDDS.
I found this video very helpful because help us actually to see, to understand what actually patient is feeling and help us to actually help them better because we can see how difficult it can be. So what's actually the criteria? The patient should have a non-speeding vertigo, and he can characterize as a rocking, bombing, swing. The onsets actually can occur within 48 hours after the end of exposure of passive motion. The symptoms temporarily reduce with exposure to passive motion, and the symptoms continue for more than 48 hours. And symptoms don't get better when you try to find another disease to explain it. So symptoms not better accounted for by another disease or disorder. Even our patient, we didn't find any actually exposure to passive motion that he could identify. He still fills the criteria. So the treatment, the most important actually treatment is the lifestyle modification with reduction. Patient has to try to reduce the emotional stress and poor sleep. So be well rested and avoid noise environments, avoid like bright lights and excessive visual motion stimulation. Here we have some tips for a patient that has migraine and mal de Débarquement when they're shopping. So try to avoid light. So there is actually glasses and for migraines that can help to cope. Avoid the store when it's busy. And shop at smaller local stores or boutique with less visual stimuli. It's also recommended to use carts so they can feel more stable. To bring a body or a rescue medication. And if the symptoms are increasing or triggered, leave the store. About medication, antidepressant is much more effective, especially as SRI, and benzodiazepine as the most quickly acting effective. We can start with 0.25 milligrams 1 time a day. That's exactly what our patient is taking right now. And then we can do a titration up to higher than 0.5 milligrams 2 times a day. If the patient is planning to travel, we can do a lorazepam or diazepam because it's the half-life is smaller, is reduced. And patients should be advised not to drive or consume alcohol when they are taking benzodiazepinics. So we always have to remember the patient about it. It's very important. So here is actually we have, there is a foundation for Mal de Débarq syndrome. It's really nice. The website is really rich. There's a lot of information for physicians, for the patients, even for family members. The month of awareness for Mal de Débarq is actually in June. And we have awareness weeks for Balancy, which happens in September. So to sum up, let's just confirm some key takeaways. First is the dizziness and vertigo by newer definitions are distinct and separate descriptors. Studies of over the past dozen years have changed the historical approach to patients with dizziness from how the patient describes the sensation of dizziness, which can lead to misdiagnosis. A preferred method puts greater emphasis on whether the patient has the dizziness is acute or chronic, episodic or continuing, and if there is an event or circumstance associated. And Mal de Débarq syndrome is a disorder of post-motion induced persistent oscillating vertigo lasting more than 48 hours. Patient usually will describe it so like rocking, bombing, swinging. And the perception decreases when the individual is back in motion. This is really, really important. And medications such as SRIs and benzodiazepine can be helpful. But unfortunately, they rarely lead to a complete resolution of symptoms. Well, thank you very much for your attention. Thank you, Dr. Stein, Dr. Bernard, my colleagues, and all the AMIQT team for this opportunity.